Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yadon.
And thank you, Braley. This is Richard Yadon, President and CEO of Managed Medicaid Services, and your host for the next hour here on the Medicaid Matters Talk Show. Welcome back, everyone. I hope the past 2 weeks have been good to you. Hope they've been productive and enjoyable. We're live today from the Managed Medicaid Studios here in Brentwood, Tennessee, just a few miles south of Nashville, if you're unfamiliar with the city. It is the healthcare capital of the U.S. Glad to be here and glad you are joining us today. Our show today is going to turn our attention to the subject of utilization management, something that health reform has got to address, and we're going to talk about what health reform might mean for utilization management, and we're going to hear about some innovative approaches to utilization in the area of diagnostic imaging. It is my pleasure to have two guests on our show today: Dr. Michael Komarow, Chief Medical Officer, and Mr. David Howitt, Executive Vice President, both from Care to Care. They're going to be joining us here in just a few minutes, so hang on. We're going to dig deep into this topic today. One of the things that I'm hearing from our audience is that you really like the wide range of topics we cover on this show. And over the past year and a half, we've heard from presidents of our industry associations. We've heard from state medical directors, state Medicaid directors. We've heard from senior nurses involved in care coordination and care management, technology innovator, and just a host of Medicaid industry executives and thought leaders. And it is that group is exactly why I created this show. There's so much going on today in Medicaid healthcare, and this is perhaps the only live and interactive forum available to showcase all that's happening. And interactive, I think, is what makes Medicaid Matters unique. This means that you can talk with me and any of our guests during the live show today. We're already set up and ready for your calls now. The number is 626-657-2125. That's 626-657-2125. You can speak with me or any of our guests while we're on the air. We really want to hear your opinions and your comments on this subject and your thoughts. If you can't call, well, we're also on Twitter, and you can send a comment or a question to @MedicaidTalk. We'll get them on the air as time permits. And finally, we hope everyone can do this. If you're there at the MedicaidTalk.com show page on our website, there is a live chat that's going on right now, and you can join us there, and we'll read your comments or your questions on the air as time permits and get those to our guests. Well, utilization in the eye of health reform is our topic today. What exactly does that mean? Well, here to tell us all about the subject are two experts from Care to Care. Dr. Michael Komarow has over 30 years of experience in radiology and radiology benefit management. He is board certified in radiology and has practiced both in hospitals and office-based diagnostic radiology for over 20 years. He's also a graduate of the Pace University Law School. So that will bring, I'm sure, a very interesting perspective to our conversation today. In the past 15 years, he has served as Chief Medical Officer of one of the nation's largest radiology benefits management companies and as the Chief Quality Officer of a teleradiology company. Since 2008, he has served as the Chief Medical Officer of Care to Care, which is a multi-specialty benefits management company. Also with us, joining Dr. Komarow, is Kevin Howitt. Kevin is Executive Vice President with Care to Care. And prior to joining Care to Care, he was the Vice President of Business Development at Care Management Technologies, which is a data analytics and decision support solutions provider based in North Carolina. He has served in senior leadership roles with responsibility for sales and marketing, product development, and brand management with such companies as Health Media, Myativa, I'm probably pronouncing that wrong, Kevin, you'll have to correct me, Time Warner, and Simon & Schuster. Gentlemen, welcome to Medicaid Matters today.
Thanks for having us.
You know, all of our guests work in a very diverse healthcare spectrum. I mean, we have people all across the spectrum, and our audience is always interested in a perspective that you bring to a number of issues that they're dealing with day in and day out. So each of you see this health reform, Medicaid. You see it from a utilization management point of view. I'd be interested in hearing your perspective on what you see as today's main healthcare priorities. Kevin?
Well, succinctly stated, more effective and efficient health care resulting in improved quality, reduced costs, and better patient satisfaction, the triple aim of healthcare reform. In our discussions with payers, we see that they are not waiting for resolution at the ballot box this November. Most are taking action to implement now, as it makes sense for their own clinical and financial concerns. A particular import for your audience, Richard, we see this particularly so with managed Medicaid plans. They are preparing for Medicaid expansion in 2014. They know that they'll be bringing in patients at higher risk for whom health care has been deferred for many years. They know there is going to be increased utilization, and they're looking to bring on the tools now to better manage that audience ahead of the wave that's coming in.
This is Dr. Komarow. From a clinical perspective, it really doesn't matter to us who the payer is or whether we're dealing with a Medicaid population or a Medicare population or just commercial lives. But what we are seeing is that the health plans and other payers are faced with this challenge that's been there for ages of how to use the resources that they have effectively. The problem that we deal with most directly in imaging is that a significant amount of imaging really doesn't contribute to patient care, and we've sort of spent the last umpteen years trying to develop tools that allow us to reduce the amount of waste that takes place. And with the expanded coverage that's about to occur, and it's already in process, the demand for services will outstrip the available resources for them unless we're more wise in how we approach diagnostic imaging and utilization of the various tools that we have out there now.
Kevin, you spoke of specific actions that you're seeing some of the payers that you're working with taking. Could you maybe give us just one or two examples of what you mean by the types of actions that you're observing?
Well, we've spoken with a number of managed Medicaid plans that are currently focused on the TANF population, membership of young families and children, and they know that the population coming in through Medicaid expansion is going to bring a different audience altogether. Childless adults and certainly the dual eligibles, which we'll talk about a little bit later, they have significantly higher risks, and we know that there'll be increased utilization. And so in beginning to think about how to approach these new members that are coming in, they are looking for a new tool set. What we've seen in our data suggests that the new Medicaid population, particularly the childless adults, will be 3.5 times more costly from a utilization standpoint than so-called typical Medicaid. And that's what they're gearing up for.
Yeah, it's going to be a huge issue. There's no question about it. I've heard that from some of our clients as well, that something's going to have to be dealt with, and I think you're right. I think a lot of plans recognize that, and they're gearing up for it. Dr. Komarow, we have a number of guests on our show that talk about different trends that they're noticing, that they're spotting, that they're trying to deal with, day in and day out. Trends that are going to have a future impact. Some of them, have an impact right now. And some of them are trends that it seems like nobody's really gotten around to. I'm curious as to maybe there's some trends that you might be finding today that you just don't see are being universally addressed.
Oh, there are
you got to narrow it down a little bit.
Answers to that question. As a radiologist, one of the trends that I see is the proliferation of imaging equipment in the hands of non-radiologists that allows for self-referral. And there are studies in the literature that indicate that doctors who can refer imaging studies to themselves or a partner or a member of their practice do so at a much higher rate than physicians who send their cases to an independent radiology facility. Trends in radiology especially tend to occur on almost a decade-like level. When CT first became available, it was the cure for everything. And the same thing has happened with MR and with PET scanning. We're getting some feedback here, so I'm sorry. And what we have tried to do is address these as they occur in an educational fashion.
Mm-hmm.
The trend that Kevin just spoke about of people coming into this market, it will bring with it a ton of pent-up demand, and that is also something that we hope to be able to deal with through the data that we collect on each patient and helping to manage them in a coordinated fashion.
Mm-hmm.
Interestingly, and many of your audience members may know this, but radiology can be a precursor to other chronic conditions that may be manifest within a population. So it gives you an early benchmark to what else might be happening.
Mm-hmm.
And particularly in the population that we've been discussing, where there are multiple chronic conditions, radiology could be, sort of like the advance notice as to other issues pertain.
Mm-hmm. We're seeing also, a lot of responses, particularly in Medicaid, from a state level, is to start cutting costs and to just, as the cure for a lot of different problems that exist. How is this being impacted in the work that you're doing, or what trends are you seeing relative to cost cutting in what you're doing?
Well, the best way to cut costs is to eliminate studies that don't benefit the patient, in terms of the radiology especially. So all of our efforts in the clinical side of what we do have been directed towards identifying the studies that are appropriate as quickly as possible and getting them approved, and then finding a way to deal with the ones that are, at least on first view, apparently inappropriate. When I started in radiology, which was more years ago than I care to admit, we were told by our chief that about 30% of the work that we did really didn't contribute to patient care. But in those days, a big deal was a $20 chest X-ray. Now we're dealing with $2,500 PET scans, and when you do a series of useless examinations, two things happen. Number one, you've burned up a lot of money for no benefit to the patient, and a significant number of those useless studies will turn up the reason for yet another study or an intervention that doesn't need to have been done, driving up expenses further. So our approach to this, and this is true across the whole radiology benefit management industry, is to try to reduce to the extent that we can studies that aren't likely to be of benefit to the patient, and to direct physicians to more appropriate examinations if they exist.
Mm-hmm. What does the when you get in those conversations, how are the primary care physicians reacting to the issue of appropriateness when perhaps there's some conflict there?
Well, we've approached this in as collegial a way as we can. We've taken efforts to put a couple of tools out there for the physicians to use. All of our criteria are on our website, along with a little primer on medical imaging. Mm-hmm. But the way the work flows, if we discover that the history provided to us with a request for prior authorization doesn't meet the guidelines and criteria that we've established, the request is reviewed again by a radiologist who can then approve the study because you can't write criteria for everything. Mm-hmm. Or if the radiologist still feels it's not an appropriate exam, we'll reach out to the requesting physician or provide them with a chance to talk to that radiologist and discuss the case. The aim here is dual. The first is to deal with that particular question in front of us in as expeditious manner as we can. And the second is to provide a two-way street for the exchange of information. Mm-hmm. There are doctors out there who know stuff that we don't know, and hopefully we know a lot more about medical imaging than a lot of the people that we're talking to, and we can provide them with sound advice. We found that using radiologists to engage in these discussions has led to a much higher degree of satisfaction amongst the primary care docs than if they're confronted with another person who's not a radiologist who's mm-hmm. trying to tell them what to do. So by combining all of these tools, both educational and conversational, we've tried to achieve a relatively high level of both satisfaction and efficacy.
Great, great. Well, we're going to stop here for some messages from our sponsors, so stay with us for more from Kevin Howitt and Dr. Komarow.
Nurses who want to stay on top of their skills know that the Nursing Informatics Learning Center is the place to go. You'll find articles, tutorials, a blog, e-zine, board-approved CE credits, links, assessments, and consultant services, all available to the global nursing community in one place. If you're a nurse or if your organization employs nurses, you need to visit the Nursing Informatics Learning Center.
By providing access to the care they need and the quality they deserve, Medicaid health plans enhance health outcomes of our nation's underserved. Listen to this letter to a Medicaid health plan that helped save the life of Juan, a 4-year-old with a rare heart disease.
All of your efforts have created a miracle for my son. Even though he was so close to death, you helped. You made a difference. Now he's coming along, little by little, step by step.
Medicaid Health Plans of America, ensuring access to better health care. Learn more at mhpa.org.
Elevating the quality of care with less cost. Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new advanced care transitions program, companies can dramatically raise the quality of care without increasing their cost. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid health care. Why don't you take a minute now and join our communications list. If you're at MedicaidTalk.com, you're there at the show page, you can put your email address in right now, and this will keep you up to date with all the latest happenings with the Medicaid Matter talk show, future guests, events, everything you need to keep you on track. We're also going to be unveiling some new features of the show in the next couple of weeks, and you'll want to learn about these as well. And the best way to do that is to be on the list. So take some time today and let us hear from you. Well, let's get back to our guest today from Care to Care, Dr. Michael Komarow and Mr. Kevin Howitt. And Dr. Komarow, I want to ask you, because I know from reading that you have spoken and written about several factors that are converging today to kind of set the stage for new approaches to healthcare. Tell me a little bit about what you mean, if you would.
Well, one of the goals of our programs is to make sure that the patients get the right study at the right time. And what we've tried to do is to provide our clients with a lot of information regarding their utilization, but more specifically with regard to an individual patient. As the number of people involved in the Medicaid world increases, one of the things that we've seen is that their care tends to be somewhat fragmented. And one of the places where we see a lot of waste in imaging is in duplication of studies or in follow-up studies that are performed at intervals that are just much too short. And our process provides an opportunity for us to inform the physicians who are requesting these studies that a particular patient already had that exam done within a short period of time before the current request, or that the interval between follow-up examinations is too short and they needn't repeat the study at this point. The ability of doing that and exchanging this information with the health plans as well is really part of our functionality and what makes us as effective as we are.
And in particular, with the advent of accountable care organizations and patient-centered medical homes, all that is increasing the coordination of care. And what Dr. Komarow was just referring to is a key role that radiology benefit management can play in that connection. And particularly where incentives are appropriately aligned, there are huge returns as well as clinical improvement that result from these models.
Mm-hmm. No question. How do you see these how do you see these things, Dr. Komarow, relating to some of the trends that we were talking about before the break?
It's difficult for me as the clinical person to see that there's a whole lot of difference with the Medicaid population and what we see in general with regard to the use of imaging. Mm-hmm. And I think that the cures that we develop for these problems in any of the fields, in any manner of how they're paid for, are applicable across the board. For example, one of the things that we do, and again, this is hopefully typical across our entire industry, is to provide information to the referring physicians with regard to the value of their particular examinations. As I mentioned, we have this posted on our website as a guide for physicians. Other companies have published similar items in book form or web form. And by having these out there, we hopefully are contributing to the more effective use of these resources by everyone. On a more direct level, when we deal with physicians, as I mentioned earlier, we do try to engage in as many conversations with referring doctors as we possibly can, in an effort to help them understand the value of the examinations that they're requesting. Again, looking at this as a clinician more than as a person involved with just utilization management, the growth of the technologies that we use over the past 25 years or so in radiology has truly been spectacular. And it's really impossible for non-radiologists to have an in-depth understanding of what the value of any particular examination may be, especially if that examination is only peripheral to their own area of specialization. And many of the requests that we get come from physicians who are unaware that there are limitations to the study that they've requested, or that they're ordering it in an inappropriate time or fashion. So the trends that are causing overutilization are really universal trends. And what we're facing now with the increase in population in the Medicaid world is, as we mentioned earlier, that there's so much pent-up demand. So many of these people have been putting off getting medical care for so long that we're likely to see a tidal wave of requests as they enter into managed care programs that needs to be dealt with in an effective way and not interfering with providing them with proper care.
And that dynamic, I think, will be exacerbated as a result of healthcare reform, which is putting primary care physicians at the forefront of so much of the care, whether it's an accountable care organization or whether it's a patient-centered medical home. It's the PCP who's first seeing the patient and prescribing these studies, and they're the ones who are least likely to be able to keep up with the advances in the high-tech imaging sphere.
By concentrating on what we do, we're in a position to keep track of the medical literature with regard to the efficacy of exams and the upgrade of the criteria that we use and constantly to keep as close to the state of the art as we possibly can be, and to think that a physician who also has his or her own specialties literature to follow can do this is really asking too much. And the whole thrust of what we're trying to do is to be seen not as a barrier to imaging, but as a tool to more appropriate imaging that is available to the payers and to the referring physicians that deal with.
Let's stay on this subject for just a minute longer, because I want to drill down into this from an aspect that I know that's a real issue in the Medicaid world, and especially with the Medicaid population. One of the things that we're hearing more and more is that fewer and fewer doctors are taking Medicaid patients. That the access to care, not let alone the cost of it and the appropriateness of it and the quality of it, just the access to it in some areas is pretty difficult, just because doctors are not going to take Medicaid patients. Can you maybe speak to how this is playing out with radiologists specifically?
As far as radiologists seeing Medicaid patients or imaging?
Yes.
I don't see that as a major problem at this point. Most radiology practices, to my knowledge, do accept Medicaid reimbursement. Speaking as a radiologist, I can say thankfully that most Medicaid radiology reimbursement, while not generous, is not terribly punitive either. And most radiologists do continue to see Medicaid patients or provide services to them. However, what you've brought up is one of the sources of the overutilization of imaging to begin with. The primary care docs, the people out there who are ordering the studies, are faced with relatively low reimbursement for their services to Medicaid patients, which means that they can only devote a limited amount of time to see each patient. And the response to this is that they tend to order a lot of exams based on limited clinical histories and physical examinations. And this leads to the ordering of a lot of inappropriate examinations. And that really, I believe, is one of the major driving forces for all of the overutilization of imaging, that it is more cost effective for the ordering physician out there to order a lot of tests than to spend a lot of time with a given patient because of the reimbursement structure that they're currently confronted with.
And that kind of brings up an interesting sidebar to that, and I'm just kind of curious as to what either your thoughts are or what your data is telling you. How much of those excess tests or excess, I guess that's the best way to describe it, that these primary care physicians are ordering, how much of that is attributed to just them not knowing what the appropriateness is for ordering that, or how much of it is them just trying to cover all bases for fear of any kind of litigation or punitive penalties for not doing enough?
Well, let me answer the second one with my lawyer hat on.
Okay.
Nobody was ever protected from a lawsuit by ordering an inappropriate study. It's nonsensical.
Mm-hmm.
The other part of it really focuses in closely on the problem. There's a lot of ordering that gets done because there's, in at least the ordering physician's mind, an outside chance that it's going to produce useful information. The whole idea of diagnostic imaging is that you're looking for additional proof that whatever diagnosis you had in mind is the accurate one.
Mm-hmm.
And you do reach a point of diminishing returns when you start ordering tests in that fashion, because number one, you can never get to 100% certainty, and number two, the extra contribution of test 2 or 3 in a sequence may be minimal. Part of it also has to go back to over-reliance on imaging as a diagnostic tool,
mm-hmm.
Asking it to do things that it really can't do. And one of my pet peeves with regard to this has to do with a lot of breast imaging where something is found either on physical examination or on a mammogram, and then the next test ordered is ordered to avoid a biopsy,
mm-hmm.
thinking that a negative MRI of the breast is a good reason not to biopsy someone. That's just false.
Yeah.
And there's a lot of that goes on. So I think you've hit on one of the contributing factors to overutilization, which is limited knowledge of the effectiveness of exams. And I think that ties in very closely with the one I mentioned earlier of relying on these exams in lieu of doing detailed
Dr. Komarow, we're going to have to
physical.
jump in here with a short break. I'm sorry to cut you off, but we'll come back to that. And we're going to come back and talk about some of the new approaches that are being taken.
Medicaid Matters is now booking guests. Who are we looking for? We're looking for people who can bring a fresh and unique perspective to the business of Medicaid health care. Do you have an idea that is unique, innovative, maybe even controversial? We want to hear from you. Go to MedicaidTalk.com, complete our guest questionnaire, and we'll be in touch with you to schedule an upcoming episode. Be a part of Medicaid Talk.
The Medicaid landscape is changing fast, and that means challenges, but it also means opportunity. Opportunity for you. And that's why you need to visit MedicaidJobs.net. MedicaidJobs.net is the place to showcase your talent to Medicaid companies, search for jobs, research the latest career trends, and register for the free Career Optimizer service. Don't wait. Go to MedicaidJobs.net today.
You're listening to Medicaid Matters on the blogtalkradio.com network.
Well, how can you bring your company's message to thousands of Medicaid professionals? It's a pretty easy answer by being a sponsor of the Medicaid Matters Talk Show. Each week we have a listening audience of several thousand, all of them Medicaid professionals and Medicaid advocates. You can reach them very easily by being a sponsor of this show. There are certainly several different options for sponsors. So email us at info@medicaidservices.net. You can get more information about that and how you can become a part of the Medicaid Talk community. Let's get back to our guests. And Dr. Komarow, sorry to have to cut you off there to jump into that, but I want you to go ahead and finish your thought that we were talking about right before the break.
Actually, I think I need to be cut off from time to time, because I can go on forever on some of these things. Kevin had a point that he wanted to make, and I'll defer to him for a moment.
Okay, sure.
What I wanted to do is put some numbers against, the costs associated with inappropriate imaging and what some of the opportunity is. because of all this rapid innovation and the increased populations coming into healthcare, imaging could soon represent 10% of total healthcare spend. And with current U.S. healthcare spending at $2.2 trillion, that's $220 billion in spending on imaging alone, or about 1.5% of U.S. GDP. So it's fairly significant dollars being spent here. And as we talked about, a lot of it is inappropriate. We are seeing ourselves and across our industry segment that an imaging program could be put in place and have an impact in the first year between 8 to 20% reduction in inappropriate utilization and improvement in costs. Mm-hmm. So there is a big opportunity. I like to say sometimes it's low-hanging fruit that health plans don't necessarily know how to pick themselves, and they are looking for expertise that can be brought to bear to help them with this. And there are other things happening as a result of healthcare reform that makes it a little bit more attractive for them to do so. With the new MLR equations that have to be resolved, mm-hmm. what they pay to a radiology benefit manager or other utilization management partner can be scored on the healthcare side of the spend, and what we relieve them of from outsourcing is all of the administrative costs. So there are things in the healthcare reform bill that make this more attractive to I like to say carve in a partner rather than carve out a service.
Mm-hmm. No question. Another area where significant dollars are being spent, certainly from the Medicaid standpoint, is in the area of dual eligibles, and there is a tremendous amount of focus right now on dual eligibles. If you go to any conference, you hear this over and over and over. Kevin, do you believe that the CMS project demonstrations that are going on right now are the best way to proceed with this, or is the work you're doing, or you're finding something else that might be a better approach?
Well, the CMS demonstration projects are meant to find new, innovative ways to address the needs of this high-cost, at-risk population that we're talking about when we focus on the dual eligibles. A lot of these innovations are rightly focused at the state level, where many other programs supporting these populations exist. Mm-hmm. In some respects, these represent so many petri dishes where policy and practice can come together as makes sense for conditions on the ground in each state. The best practices growing out of these experiments can be propagated in other parts of the country as outcomes and conditions dictate. So it's very interesting to see how all the different programs are different in how they're set up, who's eligible, how the patients are being served. And much of it has to do with the institutionalization. There was a great editorial in today's New York Times about one of the ways in which the state dealing with trying to get a handle on Medicare spending is through deinstitutionalizing, providing service in the community, and through better coordination of care, being able to save roughly $10 billion that can be reinvested into the infrastructure of healthcare throughout the state. I mean, it's a great example of how conditions in New York are being melded into, a new approach that addresses many different issues. And by the way, New York is the highest Medicaid spend in the country.
Yeah. Well, Kevin, I know you're having a lot of conversations, excuse me, every day with Medicaid organizations relative to utilization management. What do you think are some of the issues that still need to be addressed with respect to and this dual eligible population?
Well, you were right, Richard, that every conference you go to, there is a big focus on the dual eligible, or as they are now called, Medicare and Medicaid enrollees, MMEs. Mm. But when you look at the costs associated with them, it's pretty significant.
Yes.
It's $300 billion in annual spending across Medicaid and Medicare for a group that makes up 15% of the Medicaid population, but accounts for 39% of the program spending, and 21% of Medicare's enrollment, but 36% of Medicare spending. So they all understand that they need to get their arms around this, and particularly as there is risk adjustment in the fees that they can receive for serving this population. So if they can manage it properly, there are savings, and there is money that can be made in this population, and certainly save the states. And that's why the partnerships are really important between the states and between the managed Medicaid and Medicare plans that are serving.
I think one of the things that we've seen occurring is that plans that in the past looked at radiology benefit management as marginally of value to them are now thinking that with this population arriving, they need to take a second look as to whether or not the expense of hiring an RBM is now much more readily justifiable than it would have been in the past. I mean, there's no way that we can perform our functions as a radiology benefit manager without causing some negative feedback to the health plans. We do impose an extra administrative burden on the referring physician population. They don't get paid for this. And while we recognize that this is a problem and we do everything we can to minimize that disruption, they tend to not like us and complain to the health plans about having this in place. In the past, the health plans may have said, okay, it's not worth it to us to have that sort of negative feedback. Now they're thinking twice about that because the return on investment in radiology benefit management is much more obvious given the expanded population and the demand that they're going to be facing.
Yeah, I think that one of the issues so many organizations struggle with in the dual eligible is the issue of coordination of care, and that's why you have all these innovative projects, the CMS project, demonstration projects that are going on, is to try to attack that. Certainly, risk sharing and having financial incentives for improved outcomes are another issue that are likely to be addressed with this as well. How do you see all of this applying, though, just to the Medicaid portion of the dual eligible population? Maybe you can comment on that, Kevin.
Well, let me take a crack at it.
Oh yeah, go right ahead. Don't want to limit anybody.
Okay. We're used to interrupting each other anyway.
He's limitless.
One of the features. I'm sorry, we're getting so much feedback here. I don't know whether
we're not hearing anything on this end. I don't know what might be causing that.
Well, actually, one of the problems with most Medicaid care is that it tends to be fragmented among a number of different physicians. In that, if it's clinic-based, the particular patient may see a number of different doctors on subsequent visits, and those doctors may or may not have access to a complete record with regard to what's gone on with that patient. As I mentioned earlier, one of the functions that all RBMs perform is that we keep an ongoing record of all imaging studies on all of the patients that we deal with, so that we're in a position to provide the physicians who order studies without awareness of a prior exam with the location of that exam and where they can get the report. And in some cases, we might even have that report for them. So we can coordinate imaging care in that manner. The other thing that we've found that's reasonably effective, depending upon the health plans that we're dealing with, is that we can flag patients who might want to get into might belong in a particular disease management program at a very early stage, so that if we see a study being performed with a history of malignancy of some type, and the health plans offer disease management, we can let them know right away that they have a patient who might be eligible, and they can pursue dealing with that in a more effective manner than if they waited for that patient to be registered by someone else.
Mm-hmm. Well, we're going to stop here real quick to take our last break before we get into the final segment of today's show. If you've been waiting to join the conversation, now would be the time to jump in. When we come back, we're going to talk more about Care to Care's involvement with Medicaid and a unique solution that they're bringing to the table. So stay with us.
I hope you're enjoying today's show, and I want to remind you that opinions and viewpoints expressed by guests on the Medicaid Matters talk show are not necessarily those of the host or our sponsors. Thanks for listening, and we'll be back in just a moment.
Every 19 seconds, a child will die because of a lack of clean water. It is estimated that more than 80% of childhood diseases and deaths in underdeveloped countries are a direct result of drinking contaminated water. During the course of this commercial, 3 children will die. You can help make a difference in the lives of these children. By supporting Healing Hands International, you will provide safe, clean drinking water to families and villages around the world. Since 2006, Healing Hands has drilled more than 400 water wells in countries like Haiti, Ethiopia, Zimbabwe, and Honduras. Through the help of people like you, we have been able to bring the gift of clean water to more than 1 million people. To learn more about Healing Hands International and what we are doing to help, visit www.hhi.org. With your help, we can continue this life-saving work and make a significant difference in the lives of children.
And this is Medicaid Matters, the only Medicaid business talk show. We're live every other Tuesday, 1 p.m. Eastern Time. We're glad you're joining us, and we're going to be moving into our final segment here. If you want to be a part of the show, now is the time to be a part. You can reach us by calling in at 626-657-2125. You can tweet a question or comment to us at our Twitter handle, which is @MedicaidTalk. And you can also join us on the live chat that's going on right now at the MedicaidTalk.com show page. If you're on our show page, why don't you take a moment and click on the Healing Hands icon. You really need to learn more about this organization and the humanitarian work that they do. My company is a sponsor of their water well project, and I invite you to join us in this very important work. Your tax-deductible contribution will go to bring clean, sustainable, healthy water to underdeveloped parts of the world. When I learned of the impact that this has on people is just incredible. An easy way to impact the health of so many thousands. So please take time today and make a donation and join us in that cause. Kevin, I want to jump in and maybe talk to you very specifically about Care to Care's involvement with Medicaid. I know I know you work with a lot of different organizations, not just Medicaid, but I know you've had some significant involvement in our industry. So tell us a little bit about that.
Well, we've recently implemented a new Medicaid program as a working closely with the managed care organization that is administering the Medicaid beneficiaries for the entire state. And one of the challenges that we faced in that particular program is that the population previously had not been managed at all. Mm-hmm. And so this was a new type of program that was being introduced into a clinical environment and a marketplace that never had any management in the past. So we worked very closely with the health plan to roll the program out to the clinicians. And just to give you a sense of the spectrum, it ranged from federally qualified health centers on the one end to the top academic healthcare delivery systems in the state. So there was a wide gamut of expertise that we needed to interact with regard to this, and we wanted to be sensitive to their needs, but this was coming down the pike and they needed to know about it. And Dr. Komarow and our client services team worked very closely with the health plan to introduce the service. So Dr. Komarow, if you want to comment a little bit about your end of it and what specifically you did.
Well, we tried to put as many tools as we could throw at this problem into action. We did town hall meetings with the physicians who would be referring to us, and primarily with the office staff who would actually deal with us directly. We had videos that we used to show them how to negotiate their way through the prior authorization process. We invited any of the physicians who were affected by this program, either radiologists as rendering physicians or others as ordering physicians, to provide us with feedback, with suggestions on how the criteria should be structured. We tried to indicate to all of them why we were doing what we were doing and why the process that we put into place was both effective and as little intrusive as we could make it. This was truly a public relations effort, and it seems to have paid off. Our negative feedback in that state has been very low.
That's great. That's great. Dr. Komarow, what would you say
as a result, we've also been able to over-deliver on the savings that we had anticipated as well. So going about it in this manner, I think, has been helpful. There's not only what we see from a reduction of utilization directly, but there's also the sentinel effect that certainly has sets in and continues to improve prescribing practices on an ongoing basis.
As you have done this work, and I want to ask Dr. Komarow about this, as you have done this work, what would you say are maybe the 2 or 3 core issues that Medicaid payers are struggling with today with respect to their diagnostic imaging utilization?
Well, I hate to repeat myself, but it's the same problems that everybody's facing with regard to this. It's a lack of understanding of whether or not a particular study is going to actually contribute to the doctor's ability to reach a diagnostic decision. That is number 1, number 2, and maybe even number 3.
Wow.
The other aspects of it relate to something we touched on before, and that's really care coordination. When is a repeat study necessary? What studies should be repeated and which ones shouldn't be repeated? That is a very difficult problem for us and for the referring physician community, because it's very difficult to find in the literature strong evidence as to what intervals are appropriate for repeat studies and so forth. What we've tried to do locally is rely on the consensus opinions of national specialty organizations, such as the National Comprehensive Cancer Network, the American College of Cardiology, and the like, when we reach levels of making recommendations for this sort of thing. But we also rely, to a great extent, on the clinical judgment both of our own in-house physicians and the judgment of the doctors that we deal with out in the field. We try to show them as much respect as we would like to have shown to us, and we frequently get good recommendations from them to update our program to stay state-of-the-art.
I know that both of you advocate a very unique hybrid model and approach. Tell us a little bit about exactly what this looks like.
Well, it relates back to a trend that we've been talking about here, sort of the reformation of care delivery through accountable care organizations and patient-centered medical homes, where they're trying to be more coordinated, and where there are risk-sharing arrangements that the groups, whether they're a physician group, a payer, or a combination thereof, they are financially incentivized to deliver improved, more coordinated care.
Mm-hmm.
So when we talk about a hybrid model, we're beginning to look and move our services away from a traditional prior authorization program that's been traditionally delivered by RBMs to more of a clinical decision support system that puts in the hands of the doctors the tools that they need to be able, closer to the point of care, to get a quick approval. So we're developing a software as a service solution that does just that. One of the CEOs of a local ACO told me one time when we were discussing this issue, he said, where incentives are appropriately aligned, doctors don't need a prior authorization to do the right thing. They need the tools closer to the point of care to help inform the decisions that they make. And that's what we're looking at. When I say hybrid, is that we can put that front end in the hands of the clinician. On the other hand, for those who persist or show imaging that is questionable and not in conformance with evidence-based guidelines, we can put a hard stop prior authorization behind that. So wherever a group might be in that transition, and there was an excellent managed care article written in January of this year that focused on the migration of the industry, we can meet them wherever they might be.
We've been sort of hybrid from the very beginning in that the reliance on our radiologist physician reviewers was designed to be an informative tool for the physicians out there. And what Kevin has been referring to is that in addition to that, we're providing or building a software package so that when the information about a particular case is submitted to us, we can generate an approval or a recommendation based on sound evidence-based guidelines and have that very explicitly available to the referring physician. Mm-hmm. So we're going from hybrid hands-on to a hybrid hands-off with an option of hands-on system.
Well, we're down to our last minute or so here, and a lot more than I would have liked to cover with you, but I'm wondering if you just have any quick final thoughts you'd like to share. Tall order, I know. Well, that's okay. I mean, we can always, I think this is a very fascinating subject, and we can always, set up another show maybe and have you come back. What is the best way to get a hold of you if some of our listeners want to
90 seconds.
Call Care to Care in New York or see us on the web, caretocare.com.
Great, caretocare.com. Well, I want to thank both of you for being on the show today. Dr. Michael Komarow, Chief Medical Officer, and Kevin Howitt, Executive Vice President. Thank you both for spending time with us. It's been a very interesting discussion, and I hope our listeners will navigate over there to learn more about it. And thanks also, I want to say, to the great team at Care to Care for helping us put this show together. It always takes a group to do it, and thanks for also the great work you guys do with your clients. If you missed anything, you can certainly come back and hear the replay. Our next show is going to be on October 2nd at 1 p.m. Eastern Time. If you're on our communications list, you'll certainly get all the details delivered right to your inbox. And if you're not on the list, you're going to miss out. So sign up today. You've been listening to Medicaid Matters, brought to you by Managed Medicaid Services. Today's Tuesday, September 18th, 2012, and this is your host, Richard Yadon. I'll be talking Medicaid with you again in 2 weeks. Have a great day.
Ten seconds.
I think it's going to cut off. I don't think we have an opportunity to.
Thank you for using Blog Talk Radio. Goodbye.
Bye.